Today we're going to be taking a look at glomerular filtration as part of the renal series. To understand this topic, we first have to take a step back and understand the basic anatomy of the kidneys. As you may remember, we have two kidneys, and if we take a cross-section, we can see that each kidney has an outer layer called the renal cortex, as well as an inner layer called the renal medulla. Importantly, the main function of the kidneys is to filter waste products and maintain a good balance of water and electrolytes in the body. And the way this is achieved is by blood entering the kidneys via branches of the renal artery, and then the filtered products return to the blood via the renal vein. If we take a closer look at one of the kidneys, we can see that it's formed of several nephrons or filtering units, and there are approximately 1 million nephrons per kidney. If we take a closer look at the nephrons themselves, we can see that it's composed of multiple parts, and each part has a different function. For this topic, we're mainly going to be honing in on the first part of the nephron known as the renal corpuscle, and this is formed of the Bowman's capsule, which is the outer covering, as well as the glomerulus, which is basically a loop of capillaries designed to increase pressure. The glomerulus has an afferent arteriole which brings blood into the system, as well as an efferent arteriole which brings blood out. And the width of each arteriole can help to control the flow of blood through the glomerulus and into the renal tubules. Because the walls of the glomerulus are quite thin and the pressure is so high, small molecules can be forced out of the blood and into the nephron tubules through this system. To make things easier, we're going to simplify our diagram of the renal corpuscle to look like this. Again, we have the afferent arteriole which brings blood into the system, the glomerulus in the middle, and the efferent arteriole bringing blood out. The remainder of the nephron, which is seen here, along with the blood vessels surrounding each nephron, we're going to simplify on our diagram like this. In essence, this simplified diagram now represents an entire nephron, and this simplification makes it a bit easier to illustrate how glomerular filtration is calculated. When it comes to the substances around and inside each nephron, these can either be filtered, reabsorbed, or secreted. Starting with filtration, small molecules are forced into the nephrons due to the high pressure of the glomerulus, while large molecules such as blood and protein are unable to enter the nephron because they're too large to pass through the thin walls. This means that the filtrate entering the tubules should only consist of small molecules which were able to pass through these walls. In contrast, the process of reabsorption involves molecules being brought from the nephrons back into the blood, and substances such as glucose, sodium, and water are usually heavily reabsorbed. Finally, we have the third process of secretion, which is where molecules are secreted into the tubules from the blood vessels surrounding each nephron. Substances such as PAH or para-aminohippuric acid are often heavily secreted in this way. Importantly, substances entering the kidneys can either be returned to circulation via the renal vein or excreted into the urine via the ureter. And the amount of a substance entering the kidneys should be equal to the amount leaving it through these two routes. For example, in this case we have 8 molecules of substance A, and when it passes through the kidneys, we still have 8 molecules leaving it. It's just that 4 are in the ureter, in the urine, and 4 have returned to circulation. The overall amount remains the same. One key concept to understand is the idea of renal clearance, which is a measure of how well the kidneys can remove a particular substance from the blood and excrete it into the urine. To explain this, we have to expand our kidney into each of the individual nephrons, as seen here. In general, the plasma concentration of a substance, multiplied by how well it's cleared by the kidneys, should be equal to the urine concentration of the substance, multiplied by how quickly the urine is flowing. And this can be summarized in the following equation shown here. If we rearrange the equation, we can find that the clearance rate is equal to the urine concentration of the substance multiplied by the urine flow rate divided by the plasma concentration of the substance. Just to run through one example, in this case we have 8 molecules of substance A in around 100 ml of blood, which gives us a concentration of 0.08 milligrams per milliliter. If we take a look at the urine concentration, here we have 4 molecules of substance A, but the volume of urine is much smaller than the volume of blood, so these 4 molecules might be divided across just 1 milliliter of urine. This gives us a concentration of 4 milligrams per milliliter. Finally, we can measure the urine flow rate, or how quickly the urine is flowing, and this is usually around 1 ml per minute. If we plug all of these numbers into our equation, we can calculate the clearance rate of substance A, would be around 50 mL per minute. Where it starts to get slightly more complex is knowing that the clearance rate can be affected by different processes within the kidney. So the processes we mentioned, such as filtration, reabsorption, and secretion. Starting with filtration, if we have a substance which is not filtered well into the kidneys, so for example in this case only 2 molecules are ending up in the nephrons compared to 6 in the blood, then this predisposes to a reduced clearance rate. This can be justified using the equation because we know that the urine concentration of substance A is going to be lower and the plasma concentration of A is going to be higher, so the clearance rate should decrease. If we change the situation so that substance A is now freely filtered into the kidneys, so all of the molecules move into the nephrons, then it's more likely to lead to an increased clearance rate. The reason why I use the word likely is because the other processes, so reabsorption and secretion, can interfere with the clearance rate more than filtration. So for example, looking at reabsorption, if substance A is heavily reabsorbed into the blood vessels surrounding each nephron, and eventually back into the renal vein, then we can see that only a small amount of substance A actually enters the urine. In other words, reabsorption of a substance will decrease the clearance rate. In contrast, if we look at a situation where substance A is filtered into the kidney, but then a large amount is secreted, so molecules moving from the blood vessels into the nephrons themselves, then we will end up with an increased amount of substance A in the urine. Combining this with our equation, we can see that secretion will always increase the clearance rate because there's more of the substance in the urine and less in the plasma. Let's now move on to the idea of glomerular filtration, or GFR, which estimates the volume of blood filtered by the kidneys each minute. To measure the GFR, we have to find a substance which is freely filtered, so all of it moves into the kidney, not reabsorbed, and not secreted. And if we find a substance which matches all of these criteria, the equation, instead of measuring clearance rate, will give us purely the glomerular filtration rate, so the amount filtered only. One substance which matches all of these criteria is a molecule called inulin, and this is considered the gold standard for measuring GFR. The only issue with inulin is that it's exogenous, so it has to be injected into the patient, which makes it quite difficult to use in acute scenarios. Just for the sake of example, let's take a look at why we can't use specific substances to measure GFR if they don't match all of these criteria. If we take a look at glucose, all of the glucose moves into the kidneys, so it matches the first point of being freely filtered. There's also no secretion of glucose from the peritubular vessels. However, the issue of using glucose as a marker for filtration is that it's heavily reabsorbed back into the blood, and as a consequence, only a small amount or sometimes no glucose at all moves into the urine. This would lead to a severe underestimation of GFR because we haven't really measured what's being filtered, we've measured what's being filtered and heavily reabsorbed. If we take a look at the opposite extreme, PAH is a substance which is freely filtered into the kidneys. It's not reabsorbed, so there's no movement back into the blood, but it is heavily secreted, so molecules move from the peritubular vessels into the nephrons. As a consequence, you can see that we now have a lot more PAH in the renal tubules compared to the amount which was originally filtered. So we started with around 6 molecules in the blood, but we end up with 11 molecules moving into the urine. This would give us a severe overestimation of the GFR. In clinical practice, we tend to use a molecule known as creatinine to measure the GFR, and this is a product of muscle breakdown. Creatinine is freely filtered into the kidney, and it's not reabsorbed. The only downside is that there's a small amount of creatinine secretion from the blood vessels into the tubules, so we do end up with a slight overestimation of the GFR. However, because this secretion is so minimal, and we can adjust for this in our calculations, creatinine remains a good marker of renal function and GFR overall. To summarize this, creatinine is a good substance to measure GFR because it's endogenous, so it doesn't have to be injected, it's not reabsorbed, and only a small amount is secreted. If we take a look at our clearance equation, and we substitute urine creatinine and plasma creatinine, we can therefore work out the glomerular filtration rate. And the value of a normal GFR in healthy individuals is around 125 mL per minute. GFR is a useful calculation to work out how well the kidneys are functioning, and if we have a sudden decline in GFR, this will probably point towards an acute kidney injury. If the decrease in GFR is more gradual over months or years, then this may represent a chronic kidney disease, and we'll discuss both of these topics in different videos. The one disadvantage of using these equations is that they rely on 24-hour urinary collection, which is not ideal for acute scenarios. As a result, we have a system of calculating the estimated GFR, or the eGFR, by looking at patient factors such as the age of the patient, whether they're male or female, and the body surface area, and combining all of this with a serum creatinine, so just one blood test, to bypass the need for urinary collection. Here's one example of an eGFR equation, but there are different equations which can be matched depending on the situation and depending on different patient characteristics. And here we have a summary slide outlining everything I've gone through in the video. I hope you found this helpful, and I'll see you in the next one.